Good afternoon, you guys. We are going to start on the kinesiology of the hip, and it's one of my most favorite areas because it is one of the keys to getting a lot of patients better faster. So patients with knee problems, with back problems, even sometimes neck and foot and ankle problems. It's a really wonderful area to understand and grasp onto, and once you start to really hone in on the hip, you're going to make a huge difference for a lot of patients. Let's get right to the objectives. So we're going to talk about a lot of the articulations of the hip. What does that hip look like? What are the different connective tissues? What are the stabilizing components of the hip? And then we're going to get in and analyze and describe different movements of the hip and making sure we understand arthrokinematics and osteokinematics, the pelvis moving on the femur moving on the pelvis. And then we're going to get into, at the very end, some compensatory patterns that we might see with an immobile hip in relationship to the lumbar spine and the thoracic spine. Super cool. So here we go. Let's get started. So the hip joint, should be some review for us, but just in case, let's just make sure we're all on the same page. So the acetabulum is, the part of the pelvis that we're going to see is that kind of shallow, concave area in which we will have different articular areas that'll go into that. And then, of course, we have the head of the femur that starts to articulate with that. It's a diarthrodal joint, so ball and socket joint, 3 degrees of freedom. So a lot of times what we'll do is we'll take one hand and we'll bend at the wrist, make a fist, bend at the wrist, and then cover that with the other one, just like we would with the shoulder. So we're going to do the same thing as the hip when we start to go through and understand what types of motions we're seeing. Pretty cool about the acetabulum and the femur is it's actually a very stable joint. So at where we saw with the shoulder, it was a little bit more unstable just due to the congruency. This is actually a very stable environment, and this is a good review for you guys to just remember our articular cartilages, our where our femur comes into that, the different ligaments, so the ligament at the head of the femur going into the acetabulum, that ligamentum teres, and then just understanding there's a fat pad within there, there's bursa, we have a capsule that surrounds it as well. So let's just review quickly. We know that in movements, what occurs in the sagittal plane, so it should be flexion and extension. What occurs in the frontal plane should be abduction and adduction. And what about transverse plane? Yep, internal and external rotation. So let's go functions on the hip. So I love Michael Phelps. I was a swimmer in really since I was young, all the way through high school. Played a little bit of water polo at U of A. But really, so he's just here to demonstrate that hip really is there to support the hat. So the head, the arms, and the trunk. And it also provides that pathway of transmission of forces. Really that big powerhouse, right? So we understand that jumping off the blocks is this large powerhouse all the way with this big leg, powerful glutes, all that stuff. And that transmits forces so that Michael Phelps can jump in the water and swim really fast and just be an amazing athlete, but really understanding that hip really is that powerhouse. Lots of forces will go through that with all different types of movement, open kinetic chain movement, closed kinetic chain movement. Our hip tends to operate in a closed kinetic chain environment just because it's that weight-bearing joint, but it can also operate in an open kinetic chain. So proximal end in that closed kinetic chain environment would be our head, and then the distal end would be our foot. So our acetabulum is made up of all 3 bones really of the pelvis come together to form that acetabulum. And thinking that we know that the pubic bone, and you guys know that pubic symphysis is what we palpated in lab, but if we look at that pubic bone. It forms really in through the acetabulum. And then on the underneath side is we start to have that ischium come and form, and then we have the ilium come into form the other components of that acetabulum. It's really not fixed until between ages of 15 and 25 years of age. You can see that on radiographs, and pretty impressive that our bodies are built to take so many forces and adapt into that. But if you think about now, we're dealing with such a population that either is way too sedentary or highly competitive, and what is the effect on our pelvis that hasn't quite fused yet, and we're starting to see more injuries because of that, and we're not really sure, and you guys are in a great time of physical therapy because we're going to be a big part of that. That acetabulum, if you look, does really face lateral, so it sits lateral onto the pelvis, and faces just a little bit inferior and anterior. We'll remember that when we move on to the femur, and that femur is going to be well placed within that joint. So the acetabulum is concave, and it's, like we just said, located on that lateral aspect of the innominate. What is cool is it's covered with this hyaline cartilage and makes this horseshoe. And we know that there's an acetabular notch right in here, and that notch is not covered by that hyaline cartilage. And that really allows, this hyaline cartilage really allows for those contact stresses and for them to be evenly distributed throughout that. As we see, it looks like a horseshoe, and so it's a little bit easier for me to remember that horseshoe. That hyaline cartilage, if its horseshoe shape, is not all the way congruent through that acetabulum, and therefore we need that transverse acetabular ligament to connect those two. So this is that transverse acetabular ligament. It really does provide quite a bit of structure into there. We know that the acetabular labrum then is throughout there. It really does form that nice congruent, and it's fibrocartilage that rims that entire periphery. So we'll start to see that as we go into our different areas, that we'll start to see that it really is going to line that whole outside, and then our synovial membrane is going to be encompassing that whole joint, just to provide it some nutrition and some really good fluid into the area. The transverse acetabular ligament is the roof of the tunnel passage, really for those blood vessels and nerves that are entering into the hip, so it can provide a little bit of protection for that, so nice to understand that. How this is positioned, how this acetabulum is positioned, is what we'll call anteversion, and that anterior orientation of the acetabulum. It's normal for us to all have that anterior orientation, but we'll get into talk about what is a pathological condition in that. For right now, just know that in men, it's about 18.5, that angle, and then in women, it's about 21.5. There's a lot that can go into that acetabulum that, if it's too shallow, or if we start to get degradation of the connective tissue into there, can increase our risk for dislocation, so or it might just cause some more instability. And if we have instability and we have more movement in that area, what do you think is starting to happen? Yeah, there's probably some wear and tear into that area. So just understanding that it's important that those structures stay maintained. Let's clear that out of there. So our acetabulum has a center edge angle, or the angle of Weiberg. And this angle really is how we start to understand the depth of that acetabulum. And in men, it's angled about 38 degrees. Women, it's about 35. So it's the opposite of that angle of inclination that we were talking about. And the smaller the center edge angle is, the decreased coverage of that head of the femur. And so if that head of the femur is sticking out anteriorly, then superiorly, then it can increase that risk of subluxation or dislocation. Let's take a look at the next slide because it's got some just a way in which we'll start to see that angle is calculated. So as we move down and through, it's that center point of the femur in relationship to the acetabulum, and as we change in age, we're going to see that that angle is going to change a little bit. So when we're young, that angle is about 19 degrees. When we get into adolescence, we start to see a sharper angle, so 12 to 25. And then as we get into maturity, so as we start to see maybe that pelvis is starting to fix and we're starting to get more set angle inclination into the actual femur, we're going to see that the angle, that CE angle is 26 to 30 degrees. We're going to just briefly talk about a little bit of a case study. So just to start to understand that all of the angles of inclination and angles of torsion, the hyaline cartilage that is within the acetabulum and the hyaline cartilage that is within the femoral head might really play a factor in someone's pain and discomfort. So I had a 43-year-old female come in, and she was complaining of pinching deep into the groin. So sometimes that'll be called the C sign, where someone places their hands on their hips with their thumbs facing posterior and their middle fingers pointing down into the groin. Complained of pinching as she's going through a squat. The deeper the squat, the more pinching she was feeling. And so I just want you guys to start to think about all the different structures that might be causing that, and consider what happens within that labrum, what happens within that fibrocartilage and that hyaline cartilage, and then understand that the femur also has covering as well. And so if I'm going through a squat, so if you guys go through a squat right now, so if you stand up and go through a squat, some of you might even start to feel some pinching in there. So what might be getting pinched between the femur and the acetabulum? Start to think about that. I want you guys to come to class, and we'll talk about that a little bit more, and we'll try and throw that in as we keep our ongoing discussion of the hips and the mechanics of the hip and the way in which things are structured. So the femur is really the strongest bone in the body. The femoral head is placed medial, superior, and anterior, so to fit nicely into that acetabular fossa. That fovea is that rounded area, and it's the femoral head is covered by that hyaline cartilage. It's more spherical than the acetabulum, and what's really interesting is that as they've looked at multiple different studies and bodies, is that the shape of our femoral head is variable amongst individuals. We even looked at people who have the same length of bones and same type of bones, and it still has some slight variation to it. The fovea is important because that's a rough portion that lies just inferior to the top of the femoral head, and that's where our ligamentum teres attaches. So remember that ligamentum teres is what attaches into the acetabulum. So guys, what happens if this is worn away, or what happens if there's significant trauma? What do you think starts to happen to the femur in relationship to the pelvis? Do you think we gain more stability? Do we think we gain mobility? What are we needing to rely on if that is compromised? You know, in total hips, they often cut this ligament. So what's the implications for us as physical therapists as we move on? Let's talk now about the angles, really the angles of angulation in the femur, so the angulations in the femur. We're going to talk about two different kinds, so the angle of inclination, and then we'll talk about the angle of torsion. The angle of inclination is what we've just already talked about. It's the degrees in which there's a change in the frontal plane between the axis through the femoral head and the neck, and on the longitudinal axis of the femoral shaft. So for me, I always understand it as it's really that relationship between the femoral neck and the acetabulum. How much bend is in that? Is it a sharp angle? Is it a 90-degree angle? So normal, if we're talking about into adulthood, is about 125 degrees. So we would say normal is this nice line, this 125-degree line that we see. So if we look at, it's this angle of the center and then all the way through the center of the femoral head into the acetabulum. And then we have this nice arc right here. Gives us a lot of room for movement, gives us stability. But we'll see that there can be varying degrees. So varying degrees in infants, even just through the ages, we'll start to see varying degrees. And we also might see just a little bit of gender differences between the two genders. So we're going to name, if there is a shorter angle, right, or less of an angle, we'll name that coxivera. So we start to see that coxivera has a shorter angle and it's not as sharp. So we see that there's increased congruency of the femoral head into the acetabulum. If we have a larger angle, we're going to know that that's coxivalga. So coxivalga as we move into that larger angle of inclination. So which do you think, coxivera or coxivalga, is going to have a shorter limb? So think about that. And then I also want you to think about which of the two, between coxivera and coxivalga, is going to have greater increase in hip abduction function. So think about that as well and start to think about why would we have that. In infants, our angle of inclination is about 150 degrees, but as we start to go through adulthood, where we're getting increased weight bearing, we're getting increased stability through our musculature, we're going to gain lesser of an angle, so we'll get to closer to that 125. As we move into being a little bit older in our life, we're going to start to see maybe some decrease in that angle, and maybe that's just because that trabeculae bone is starting to get a little bit worse. Gender differences, women will have a slightly less inclination due to the width of the pelvis, and we know that is to support the act of giving birth. Okay, so angle of torsion is how much movement is occurring in the transverse plane between the axes of the femoral head and neck and the axis through the distal femoral condyles. So we'll talk about femoral anteversion and retroversion might be a component of when someone has a toe in or a toe out pattern. So if you guys just take a couple steps, so stand up and take a couple steps and just let your feet lie. Most of us are going to have slight toe out, meaning that our toes aren't pointing straight forward. So if our toes are pointing out, we're going to call that femoral retroversion. So it meaning that our angle of torsion, we're sitting a little bit more posterior. If we have a femoral anteversion, we're going to see some toe in, and so we're increasing that through there as well. We're going to dive in a little bit deeper into that, and we're going to talk about coxivalga, coxivera a little bit more as well. So coxivalga is pathologically, it would be greater than 125 degrees in adults. That's something that we would want to just measure and understand. And what happens if I gain increase in that length of that? So I have a longer angle. I might have the same length of my femoral neck. It's just the angle is now changed. So I'm going to see that I'm going to have a longer limb. If I have a longer limb and that angle is sharper, I'm gonna gain understanding that my hip abduction function is going to start to decrease. Think about that length-tension relationship between the origin and insertion of our hip abductors. We're going to not be optimally aligned, and so we're going to start to see that there's some greater instability that occurs in this. With this angle, it increases the femoral head load. And because it doesn't have that nice angle of that femoral neck to take some of that, the femoral head is going to take some more load. So if that femoral head starts to take more load, what starts to happen to the articular cartilages in that area? So if I'm getting more compression in through here, I know that I'm going to get just changes in the way in which my bone is functioning, but I'm also going to understand that if I'm increasing that femoral head load, that the femoral head is going to take increases, but also those connective tissues are going to start to become fibrotic. They'll start to become dehydrated, and they'll lose a lot of their functioning because they now are just trying to gain stability, so they might become fibrotic in that area and just want more wear and tear. So these are some people that we might be concerned with later in life are going to have some maybe have to undergo a hip replacement because they've just now worn away all of that articular cartilage, and now we're getting some bone on bone, creating a very painful scenario, or it might not be painful, but we might have a significant amount of giving out. So coxa is really the opposite. It shortens the limb. It increases that stability and that congruency. It increases that hip abductor effectiveness, and ultimately decreases that load on the femoral head. It can increase the load on the femoral neck, though, and so these are some people we might see later in life that as the bone starts to become less strong, that we're starting to see some femoral neck fractures. It does improve that joint congruency, so the joint, they might not have as much motion, say in internal-external rotation, because that joint's so congruent, but they have a lot of stability. So they're probably not at risk as much for increased dislocations or that kind of scenario. This is really just a slide for you guys just to hone in and take a look at and just appreciate some of the differences side by side. I really liked it when I was just reflecting on what the difference is and understanding that when does it become pathological, what is normal. So coxa vara, coxa valga, remember, are more what we would say is a pathological description. And then, but all of us have some normal angle of anteversion within our femur. Okay, so let's touch on angle of torsion. So that anterior torsion equals relative lateral rotation. So internal, external rotation, right? So what we'll see is in newborns are going to have much sharper internal rotation. Adults get out of that. They don't gain as much of that because a younger person is going to have to gain stability, and so they're trying to gain stability with that relative angle. Remember, this is that transverse plane between the femoral neck and condyles, and this might start to decrease with age. The angle of anterior torsion will decrease with age, and it's pretty amazing to see that as we move from 40 degrees to about 10 to 15 degrees in adults, the angle decreases about 1.5% per year until we become skeleton mature. We start to see closure of those growth plates, usually symmetrical, right versus left. So normal adults will have normal toe out right versus left, and when we start to look at someone's posture and gait, if they have asymmetries within there, we start to understand that might be contributing to their pain. Femoral anteversion is considered to exist when the angle of that anterior torsion is greater than 15 to 20 degrees. A reversal of that would be femoral retroversion, really occurring when the angles are less than 15 to 20 degrees. It might not be pathological or might not even be diagnosed, but variations in the degrees of anteversion and retroversion can also depend on how we assess this. Is it a static measure? Is it a CT scan or X-ray? What are we looking at clinically? Are we looking at the whole global kinetic chain, or are we just taking kind of a small snapshot of what's occurring? Although there are really some structural deviations that occur, such as femoral anteversion, coccyvalga, those guys maybe tend to occur commonly together. They might not, they might occur independently, but we might start to see that those occur together. And the deviation warrants really that careful consideration that the hip joint function of the joints proximal and distal to that are also affected because of that. We might see what starts to happen if we do have a greater angle of anteversion, and we also have coccyvalga, that knee and the foot are now changed in relationship to space. So like we said, we'll start to see some toe-in that might occur with that. Let's go to the next slide, because I think it's a really good, nice picture to see what we would consider would be normal movement or normal angle of torsion versus where we start to get into some abnormal movement. So normal is we have that 8 to 15 degrees. And we need that, and we want that. We have to have that in relationship to the position of the acetabulum, in relationship to the femoral head. But as we start to see that angle either go more medial femoral torsion or more lateral torsion, we start to see that there's a change in the axis of what happens to the knees. So if we have a medial femoral torsion, that we're seeing that this is an abnormal position, and that we will get internal rotation of the femur and internal rotation of the tibia, and this can really, the lateral tibial torsion will develop because it's trying to compensate for that. And the foot placement might look a little bit better, but it's actually not better because of that. So we'll start to see some compensations that might happen because of this. The medial femoral torsion and femoral anteversion are same abnormal conditions of the femur, but their designation will talk about what's happening in relationship to the mechanics at the hip and then the mechanics at the knee. So the medial femoral torsion that we see, we might be looking more at the knee joint and what's happening there. Anteversion, just a review, it predisposes people to an anterior dislocation because we don't have as much coverage. It increases joint degradation. It weakens the joint, and what we'll see is a lack of external rotation at the hip joint. Retroversion is opposite. We're going to see a lack of internal rotation with retroversion and an excessive external rotation for stability. So let's talk about just ranges of motion and what this will look like. And so we'll go through together and just see if we can do this together. So flexion is going to be 0 to 120 degrees. Hyperextension, so that's from neutral, will be, maybe this should work. There we go. Hyperextension is going to be 0 to 10 degrees. Abduction, so what happens if we bring our leg out to the side? Typically we're going to be able to achieve about 45 degrees of abduction. Adduction, we're going to get between 30 to 40 degrees. External and internal rotation. So external rotation about 45 degrees, and then internal rotation about 35 degrees. Internal and external rotation are going to become pretty imperative for you guys and all of us to understand in relationship to the function of the hip. So closed packed position. So this is when there's the most tension and congruency occurring at the hip. It would be full extension, full internal rotation, and full abduction. So that's when, if you do that with your hands, so if we make our cup of our acetabulum and we do extension, internal rotation, and abduction, we're going to understand that that really jams that femoral head into the socket. Okay, let's jump in and talk about what are our open packed positions. So open packed for the hip, which is where we might do a manipulation, where we might just do some nice gentle distraction. It's going to feel really good for our patients with some osteoarthritis in there. Is open packed would be 30 degrees of flexion, 30 degrees of abduction, and slight external rotation. So if you think about, if you guys lay down and you're just nice and relaxed, your hip automatically rotates externally just a little bit. And we like to be in a little bit of adduction and a little bit of flexion. The capsular pattern, so when we start to see that that capsule is being shortened or tightened, we'll start to see that there is a pattern that patients are losing flexion and then abduction and then internal rotation. So flexion is a little bit abnormal to lose, right? And so we would be concerned that this is starting to happen and people aren't able to get into that. And then abduction and internal rotation. Internal and external rotation is so important for the mobility of our hips and the ability of our spine to really take the forces like it should. So we want to understand that. So guys, if we go through this together, if we maybe just stand up because our graph is filled out already. So if you guys just go through and maybe we'll just stand up together and pull your knee into your chest. What you'll typically feel if you're a string bean, like my son Jack, is he would have a firm infeel, meaning that that capsule is kind of stopping some of that flexion. But if we have big muscles and maybe just or some more soft tissue, what flexion might be limited by those soft tissues around that. If you guys go bring that right leg back into extension, that's a firm infill, so those nice strong ligaments, that Y ligament stopping some of that, plus we get that capsule coming into play. Abduction is going to probably be more firm. You might get some soft tissue contact, but it's usually a more firm infeel. And then adduction is primarily maybe going to be soft tissue is going to stop that, or you'll feel some of that firm infeel as well. If you guys just go through internal and external rotation, so kind of jam into that, or stand on your leg and rotate over that. So that's going to take you through internal and external rotation in a closed kinetic chain. You'll start to feel those stoppings of surfaces is due to that firm end feel. Okay, guys, we're going to stop at this point for this part of the lecture. And then in the next part, we're going to jump into the arthrology, so arthrokinematics, taking a look at osteokinematics together. So just really dive into that and start to analyze what's going on with your body. So be prepared to not only take some notes, but maybe stand up and feel some things and start to gain a really good understanding of that really good relationship between the femur and the pelvis and what's happening with that. So stay tuned.